Next, we have Paul Moulton from Isle of Man Television. Good afternoon, Paul. Fast am I.
Good afternoon. The question is for Mr. Ashford. The numbers you gave out today and every day, I know before you talk to us, you do a briefing to members of Tynwald, and the numbers are never quite the same because obviously you appreciate some have been published from time to time. So can you explain why today you tell us, 56, but you told members of Tynwald 108? Where's that come from?
But it's as I said, it's a snapshot in time, so we can only go off what has been processed and confirmed. Things carry on as the day goes on, so there is stuff that is not yet fed into the system. We are looking to change the way the system works so that it becomes a much more of a less manual process for people feeding in. So the snapshot at the point I gave, and that's why today I stressed that it is a snapshot and figures as they are confirmed are likely to rise throughout the day. The actual confirmed at 3:45 was 56. The briefing that was given to Tynwald members included what is likely to be towards the entire end of the day.
So why not just give one number to everybody, really?
The actual official confirmed at the point of the snapshot is the 56, because that is what's being fed into the medical systems.
When is it going live? You keep talking about this. How long now?
So I believe within the next few days.
Okay. My next question's for Dr. Hewitt, really. The other day you were talking about symptoms and you were pushed, maybe there should be others added to the list, and you declined to do that. I was speaking to somebody who I know really well, and he had a very, very severe headache. Now, he knew something was wrong. He knew also he couldn't get seen by 111 because he didn't hit the criteria. So effectively, he had to make up the other items just to be seen, and he was positive. Now, this is not the only case, because I've seen it on social media. Even the track and trace team have put on themselves that they're seeing a lot of people, the only thing they're getting is a very severe headache. Do you think it's time to change those specifications now and add that to the list?
This is a very difficult one to actually take a definitive call on. If you look, and you can do it yourself just by Googling, you've got a lovely smile there this afternoon, Paul. It's always such a pleasure talking to you. So you go and Google, and in fact, you can report back to me tomorrow. Here's some homework for you. You can Google a selection of countries. You only need to do ones where they're English speaking, and look at their COVID symptom definition, and you will see that there is a huge variation. So Guernsey has a great long list, which they based on a local survey that they did. Now, the problem with a local survey is that it's a retrospective survey based on what people remember and then put on a tick list. So there's all sorts of methodological issues around that. Gibraltar did something similar and came up with a similar list. Australia still sticks with the basic 3 symptoms that we had right back at the beginning. WHO has a longer and much more nuanced levels of lists. ECDC has the same list that we have. Ireland has that list because they follow ECDC. England has a 3-symptom list. So you pay your money and you take your choice. One thing you have to remember, and certainly our 111 colleagues will tell us this, is that you have to manage demand somehow. Now, one of the problems we have with all the vague and non-specific symptoms is it's very difficult to tell whether someone who reports with those and goes on to test positive to COVID, whether the COVID actually caused the symptoms or whether they were actually asymptomatic for COVID and just happened to have another random symptom that wasn't necessarily linked. So there is no perfect way of doing this, but one does have to try and balance demand with supply of tests. And we have to say that the approach we've taken so far has worked very well. It managed to keep us with the 8 months of COVID-free that we've all enjoyed. And at the moment, we're not planning to change the 111 criteria. Thank you.
But you accept that the headache could be, and it's definitely, potentially, should be on that list. Even if you don't change the list, are you accepting it could be a cause, a factor?
We don't know, because the evidence to link the specificity of those symptoms with COVID is not yet good enough. It could be that somebody is asymptomatic for COVID, but happens to have a headache or muscular aches and pains. We don't know, because the data isn't good enough to look at the sensitivity and specificity of all those non-specific symptoms as predictors of the likelihood of COVID.
So you are accepting that if people have a headache, they think they may have it, they actually have to make up other things to get seen. I mean, that's what we're talking about here. Somebody thinks they've got it, they want to be seen, and you're saying a headache alone is not the criteria to go for a test.
No, against the ECDC criteria, which are followed not only by us, but the whole of the European Union, including Ireland, as I just indicated. That is the approach we're taking. We can't rule out that it'll miss some people, but then, as with any screening test, and effectively that's what we're saying these headline symptoms are. They're a screen for COVID. So there will always, for any screening test, be people who did have the condition but didn't meet the criteria of the screening test. There's no perfect way of doing it without either overwhelming the system or moving to a system of just random population testing. And actually, at the moment, we're getting a higher yield by going for the people with the front rank symptoms.